A very good evening and welcome everyone. On behalf of Voice of Healthcare and Viatris, allow me to extend a warm welcome to all the panelists who have joined in for today's panel discussion and also to all the viewers who have logged in for this live discussion. Today, with our expert speakers, this panel discussion aims to focus on the cancer treatment landscape in India with a lens beyond medicines. This discussion is brought to you by Voice of Healthcare in collaboration with Viatris. And to speak on the topic, I'd now like to introduce the speakers. Dr. Rekha Bansal, she's consultant medical oncologist, Apollo Hospitals, Hyderabad. Welcome, Dr. Rekha. Professor Dr. Ghanashyam Biswas, sir is consultant medical oncologist at Sparsh American Oncology Institute, Bhubaneswar. Welcome, Dr. Ghanashyam.
Thank you, Kripa.
Dr. Vinayak Munirathnam, he's senior consultant medical oncology at Fortis Hospital, Bannerghatta Road, Cunningham Road, Bangalore. Welcome, Dr. Vinayak.
Thank you. Thanks.
We also have Dr. Kripa Bajaj. She's consultant medical oncology and cancer genetic clinic at Indo-American Cancer Hospital and Research Institute at Hyderabad. Dr. Kripa would be joining in a couple of minutes with us. Also to add on, Dr. Vinayak, along with leading his expert views, will also be leading the questions and answers round for this discussion. So without any further ado, I'd like to hand it over to Dr. Vinayak. So please take it over.
Sure. Thank you so much. Thanks a lot, Ms. Kushbu. So I welcome our esteemed panelists and a warm welcome to the attendees as well. So our today's discussion would be on cancer, not only on cancer treatment. The lens for today's discussion would be focused beyond medicine in cancer. Now we all know that half of the world's population lacks access to full health services, and more so when it comes to cancer care. Now certain regions do not have access to even the basic facilities, and they are denied basic medical care. Now when it comes to oncology, that is in cancers, we always speak about and feel very proud about having awe-inspiring advancements in terms of diagnosis and treatment. But can we say the same about the access to these advancements? Meaning, can we say that there has been progress in terms of making things accessible to people across all subsets? That has still not happened, sadly. And unfortunately, this gap is very huge. And this is what we call as the equity gap in medical services. And that at times costs lives as well. And for people of certain strata, certain groups and regions, even there are barriers in every turn when they seek medical facilities. Now, to address this particular gap, which is actually a global issue, it is not like it is only the underdeveloped or the developing countries. Even the developed countries have this equity gap in medical services. Now, to address this gap, 2022's theme for cancer awareness and treatment has been called as Close the Gap. Now, while on the other hand, accessibility to quality treatment in India still pertains as one of the major setbacks for us to, follow this theme or to make this theme accessible for everybody. So, my first question would be to Dr. Ghanashyam sir. So what is the current status of cancer screening, cancer treatment, and its accessibility in Tier 2 and Tier 3 cities? Do you feel that there has been any progress in accessibility for cancer treatment, especially in these regions?
So, in last 2 decades of mine coming back from Tata and in the Tier 2 cities, so I think in terms of diagnosis, in terms of treatment, so there has been a sea and a phenomenal change. So definitely we are lacking in screening part. So even if I ask being an oncologist, so my family members are itself they don't go for a screening. So that's the problem that we as a countrymen and the oncology population we are seeing that the screening part is absolutely lacking. On the other hand, so there are people who comes to you who doesn't have a 2 meals course, but they come that there is a miracle happening in America. So is that drug available to you? So there is definitely a disparity, but in regards to diagnosis and treatment, so I think there is phenomenal changes in terms of diagnostics. So we are moving into a molecular era. So I thank many of the pharmaceutical companies who have come with the supported coupons. At least a quite a good population of patients are actually. So one time a BRCA used to cost 60,000 rupees. So with the help of the coupon, so at a 5,000 rupees or even at a free, so you can have a BRCA done. So molecular markers in lung cancers, which can be a 40,000, 50,000 of broad base. So today you can do at 8,500 rupees. So in Odisha, state of Odisha, which is supposed to be a tier 2 cities, so most of the common drugs in oncology, not the targeted therapy, except trastuzumab and rituximab, they are absolutely free because the males are covered around 5 lakhs and the females are covered around 10 lakhs. So which probably caters most of the population, except many targeted therapies in many diseases, including the orals, and the immunotherapy is not being covered. But this is a phenomenal change I have seen in last 3 years. And so rest we can always discuss about the clinical trial aspect because I don't want to cover it right now.
Right, right. So you feel there has been tremendous advancement, at least in your state, with respect to accessibility of treatments in
Yeah,
medical oncology. So
absolutely.
how is it about, say, different branches in oncology, like radiation oncology, for example? So how accessible is it, sir? So
So I
patient
think
have,
so. So be it any corporate or even the ESI, CGHS, ECHS, there are so many government and So radiation has never been a problem. So radiation, so
right,
everybody gets the good
right,
radiation. So the problem with it with the surgery, the problem with the best medical oncology treatment. So we are at this moment getting at the minimum or somewhat more than a minimum treatment for cancer treatment in regards to medical. But radiation, I think, is not a problem because even IMRT, IGRT are getting covered in the even the national scheme and the state schemes.
right, right. So Dr. Rekha, any difference of views, or would you like to add anything to it in your clinical practice, or what have you been seeing so far?
So I actually completely agree with Dr. Biswas has said. Definitely things are improving, and like Sir said, yes, diagnostically we are getting better. We have more accessibility. We are able to, with the help of the pharma companies, we are able to do more diagnostic tests. But I'm actually quite happy today that we are having a very pertinent discussion here, rather than discussing immunotherapy and the trial data. Today we are talking about how our patients can't even afford immunotherapy. I would say 90% of my patients, they with great difficulty, they are able to take even chemotherapy, forget immunotherapy alone. So that discussion never reaches there. uh,
Yes,
and it's not just about administering chemotherapy. The supportive care, the peggrafil injection, or I mean the filgrastim injection itself is a burden to most of my patients. So we are far away from talk calling standard of care, which we very comfortably talk in our meetings. But
yes,
I don't think even 95% of my patients cannot afford the treatments.
right.
So
Okay.
yeah.
Right. So, like Dr. Rekha rightly mentioned, my second question was that to Dr. Kripa, who hasn't joined us yet. But in terms of quality treatment, its accessibility and affordability. So, how far are we from the ideal situation? That is the standard of care, as Dr. Rekha already mentioned. So, sir, Dr. Biswas, sir, how is it for you in Orissa? For us, as Dr. Rekha said, the standard of care is still far from reach of many of our patients, especially treatments and protocols which involve biologicals or immunotherapy. Not many of our patients are able to afford. So, what are your views on it, sir? How can we make a difference there?
So Dr. Vinayak, so I think so the ideal treatment, even countries the developed countries are probably also facing a problem, and that too post COVID. This is going to be a scenario for rest of the world also, and that's the reason that so many biosimilars and generics trials we are into. so
Yes,
so that
yes,
so that US or the European market can take it. So the ideal cannot be reached. So there is something like minimum, and the bare minimum. So if that can be offered, I think so, that because still the Indian population more than 55% are in a rural populations. So when you
yes,
do a camp at a larger cohort, so we see that the cancer diagnosis itself makes a big news for them, because they are not aware that a fungating mass or from the breast or a oral cavity, and so they were treating with the local treatment, and suddenly so cancer diagnosis itself is a big news for them. So I think for our country, such a big population, so we are moving in the right directions, and with the government health coming into picture, with the
yes,
NGOs, and with the clinical trials, so we can discuss more at a clinical. So since our population and beyond our fraternity, people, when they will actually understand the importance of clinical trial, so I think so many of our patients are going to be benefited, because that's the hardest and the fact rule, that so people are not coming into the forefront, because their primary physicians or even the educated mass, they still think that clinical trials means guinea pigs. So but I understand in my 22 years of oncology journey, so today's clinical trials are much more safer, because you are going to get a standard drug. So the difference is either the original or the generic, and so there is hardly any placebo trial at this moment. So once we understand that, so I think that this going the close the gap. So the context is going to be definitely. So we are going to minimize that.
yes, yes. So having said that, I think we should also be very proud and happy that the cost of treatment, what we offer our patients here in India, is much less as compared to the developing countries, and we get the same treatment here, isn't it? Don't you agree, Dr. Rekha? We,
Absolutely, absolutely. So there is no
yeah,
second.
Totally agree. I
yes,
think it's a boon to have these generics, It really,
right,
it has changed our practice. But unfortunately, in Telangana, so yes, we are closing the gap. The National Cancer Grid has been established. We are trying to come up with our own guidelines. We are moving there. But unfortunately, in Telangana today, even under the government scheme, I think it's criminal to treat a lymphoma without rituximab. It's criminal to treat a HER2 positive breast cancer without trastuzumab. But our government
exactly,
scheme as of today is not covering under Telangana. So uh,
right, right.
So
we
Dr.
are
Rekha,
moving
so
in that direction.
Odisha gives trastuzumab and rituximab free. So they have, so that it is covered under.
Congratulations. Unfortunately, in
That is
Telangana,
one
we
gap
don't
we
have
should
that.
close. I think the gap of borders also needs to be closed, isn't it, sir?
Absolutely. Yeah, absolutely. Yeah.
Right. Another question, can you please share your experience in your practice about the common diagnosis and screening guidelines of cancer in India? And do you see that there is any difference from other parts of the world in terms of guidelines or the screening practices that we follow? Or do you want that it should be, region specific? And do you want any differences to be there, or should we just extrapolate whatever the West tells us about the guidelines? What are your opinions, Dr. Rekha?
So I think yes. Starting with the screening. First of all, I was saying ki treatment should not be extrapolated because I think we are different. We react differently to different drugs. We all know some drugs cause more toxicities in Asians. Some drugs cause more toxicity in Westerners. So extrapolation is not good. Like sir was saying, we should encourage more trials. Indians should be represented in trials more. Only then we will have our own data, and at the ground level as clinicians we should try to collect more and more data so that we know how our patients are responding. So I understand that's a total different discussion, but to start off with the screening, yes, I think the screening guidelines cannot be adapted because we come under low middle income countries. First of all, we cannot use the same screening guidelines. Our most common cancers are different. I mean, so in India, uh, breast, lung, cervix, oral cavity being the most common cancers. So, whereas we hardly hear about cervical cancer or for that matter, even oral cancers in other parts of the world. So, we cannot
Yes,
extrapolate the
yes,
same screening guidelines. The screening guidelines are bound to be different. So though we recommend annual mammograms, in the West, it's recommended that annual mammograms be done, but in low middle income countries, at least biannually, mammogram can be done in women above 40 years of age. Cervical
Yes.
cancer, of course, because it's more common in India, I think WHO guidelines are based on the Indian data. So once in 3 years pap smear, or once in 5 years the HPV DNA test. That is what we are following. But reach is not as much as, I mean, so population based screening guidelines are available only for breast, cervix, and oral cancers in India. We are yet to adopt lung cancer guidelines, though smoking is
Yes.
common. And India is, I think, third in tobacco consumption in the
Tobacco
world.
consumption.
So,
Yes.
yes, and contributing to the oral cancers too. I don't think we are adopting you know, population wide screening
Correct.
guidelines for lung cancer or even oral cancer. So
Yeah.
first of all, awareness has to start, and only then we can encourage more and more screening programs. So
Correct.
screening protocols are different, definitely, and long way to go again, even with the screening guidelines.
Yes,
Yeah,
yes. Even and when it comes to guidelines, I think for diseases like oral cancers, we should be the ones making the guidelines for the number of cases we are seeing and for the number of patients
agreed.
we treat, as compared to the developing, I mean, developed countries where there are probably hardly any cases of head and neck and such things. So, Dr. Ghanashyam, sir, any views on this?
So Dr. Vinayak, so now so that taboo is also gone, because last 5 years what Dr. Kumar Pravas, Banita and Vijay Patil have been publishing in head and neck, and this year there are around 20 plus Indian papers, and that too there were many oral presentations also. So I think
Yes.
in the last 5 years, so absolutely, so bang on. So we are nowhere behind. So the TMH, the AIMS group, Dr. So the head and neck again publication is there. So I think so we have definitely closed this important gap. So we are absolutely now bang on. So I think so even the many newcomers who are so so scientifically updated. So it's
Yeah.
good to see the people that we are in the right track.
Yes, even the trials which we present our data now, I think the world looks at it in a very different light, like they used to do it before. So I think now, whatever data we submit, I think it has a lot of meaning world over, isn't it? So
Yeah,
as
so the
compared to what it
so
was.
in the ASCO, the whole Twitter was buzzing into only Indian papers, low dose immunotherapy, the head and neck trials, so
Yes,
what
yes,
not. So this is good to see, So you feel so happy that so that
Yes,
our
yeah.
people also.
yes, yes.
Yeah, it's a strange pride, though I'm not even part of the data, but I take pride that it's an
I'm
Indian
also not a
paper.
part, so I am just an ex
Yes, yes.
alumni. But
Yeah.
yeah, so our people are only doing so. So they may be a senior, maybe a junior, but absolutely that
Yes,
makes more sense. So we are talking about our own data, so that's more important.
Right. So I don't think Dr. Kripa has joined yet. We could have had her views as well. Anyway, so as we have been discussing, where there is progress, there is a lot of hope, and I think that is where we are headed into right now. And the only way we can bridge this gap would be, as a community, we should rally around the vulnerable subgroups, the people where healthcare is still lagging behind. That is where we need to concentrate. And we all need to innovate and collaborate across borders. As we have been discussing, I think the policies from state to state varies. So I think we have to collaborate across borders and improve the awareness and infrastructure pertaining to cancer treatment. So coming to the infrastructure and modernization of cancer treatment in India. So there is a lot of scope for improving the infrastructure and the current situation, be it government or even the private sector. So the scope of improvement, in general, or in my opinion, would be to start with educating the public about cancer prevention. Like, for example, our listeners in this particular forum, they could be non-medical people who are part of the forum, so they can spread a lot of awareness among general public. That would be like a very, very important step to take. And apart from that, equip healthcare professionals with skills and knowledge and the inequity. So they have to be made aware of this inequity so that they become more aware. And local programs now, like we see in vaccination programs, if you look at the vaccination drive in India, there have been so many campaigns and they have reached even the remotest parts of the country. So something like that, an awareness programs have to be planned that reach out to a large group of people, even in the remotest areas. And another thing would be to resource all health centers, even the smallest centers, with small things which are necessary to do basic screening. That is something which we can think about and the government should implement. And data maintenance, as Dr. Biswas sir has been rightly saying, the trials now and the data keeping now has improved largely. So we have a lot of data so that we are able to know how our own patients behave, what is the regional scenario for us than extrapolating data from others. So that is something we have done really well in the recent years. So these are few things which we can do. And another thing is we need country-specific programs which address our unique needs, like Dr. Rekha rightly mentioned, that with screening programs, we have our unique needs, and that is something we have to target. Coming to that, it is still a stigma. So I have a question for our panelists, like certain awareness programs for eliminating the stigma with cancer. So what steps would you propose, and the importance of timely screening? Now, stigma, I mean, whenever there is a suspicion on, or whenever the word cancer is mentioned, there's a lot of stigma associated with it. And there's a lot of ostracization where they are secluded from the society, especially with the cervix and breast cancers, where women, they are very reluctant to even seek medical help. And even if they have to go to the doctor in certain regions, they probably have to take permission from the household. So there are a lot of barriers they come across. So how do you overcome this stigma, and how do you spread the awareness? So Dr. Rekha, would you be able to share your thoughts on this, please?
So I think it's a vicious cycle, and somehow the cycle has to be broken. So I don't know. I have this thought in my mind. I don't know whether it will be successful or not, but we could have anonymous groups, even if patients don't want to reveal their identity, anonymous groups of cancer patients where, because I think no one can understand a cancer patient better than a cancer patient. So if they go out and tell their stories, more and I mean the success stories, more and more patients will understand that it's not that bad. I mean, treatment actually benefits the patient, the side effects are manageable. So probably one idea is that. And I mean, yeah, we can contribute in, lowering the stigma associated with it. So most so often patients come to us and they say we don't want to tell our relatives. They will ask me what happened to my hair, what happened to my skin. So yeah, it is still very stigmatized, and we should try and break the myths, try and encourage them to tell others. And today, in fact, today in my office I had a lady who for last 10 years have been carrying a fungating mass and never dared to even tell the family. So it's very, very difficult, but all of us should contribute in our own way, and cancer patients should talk more rather than not talking.
Yes,
Yeah.
yes. So how often in your clinical practice do you come across cases like this, Dr. Rekha, where they have neglected for a long time, or they have had this reluctance to seek medical help? So is it like most of your patients like this, or?
Yeah, it's a commonplace scenario. Unless someone is like, educated, young, working in the IT, yes, then they definitely Google their symptoms, then they come beforehand. Otherwise, most of the population is still rural, and only in advanced stages they come to us, or they belong to low socioeconomic group and they think there are more other important things than their health itself. So
Yeah, so you feel that socioeconomic status has a lot of impact on the way they seek medical help, and probably even
totally.
the cultural differences. Yes.
Yes,
So,
yes.
what are your views on the same, Biswas sir?
So I think so. How many of our normal people or the community is going to follow Dr. Rekha or Vinayak or Dr. Biswas. So people follows cricketers, celebrities. So once a celebrity is diagnosed with a cancer, they take the next flight to XYZ country. So the people come to us. Suppose the CA ovary comes, so they think that this cancer is not being treated in our place or in the country itself. Somebody gets a germ cell tumor and gets a BEP outside. So people think that BEP is a very phenomenal thing which is not done here, right? That is the first thing. So unless and until people or celebrities or those who act God, so if they don't come in the forefront and speak to the people, so I think it is difficult. Now Sanjay Dutt is getting treatment under one of our colleague, and so he came last year. We had a meeting. So he vows that I am getting treatment, so he's getting immunotherapy, and 10 people comes now, you see. So the scenario is going to change. And you see our people there was a lots of hue and cry when these three stars were advocating oral tobacco. Like people used to see the smoking, though now you see a smoking alcohol are banned, so these are injurious to health. So I think so this has going to change, because they themselves has something to contribute to the society. It is not only the entertainment. So beyond that entertainment, they have to pass on a message to this larger community, so where awareness, which is the main key, is at its lowest. And
Yeah.
we see people, so as Dr. Rekha said, so they wait for, I don't know, so what they are waiting for. Even Dr. GK Rath says, so we have T1, T2, T4, but our head and neck patients or a breast cancer patients are beyond T4, so it can be T6, T10. So a new definition or staging has to be created. So people come to us, so they get some relief, they have discontinued treatment. Even they are on the government scheme also, they don't follow up with us. So they follow all rituals, but the treatment is not their major interest. So
Yes.
people start their treatment delay, people break their treatment in between, people don't finish all their treatment. So compliance are issues are there, and with that the whole taboo, the myths among the medical itself and the non-medical fraternity, and definitely some amount of nutrition and rest other issues are always there. And COVID time we have already seen. So people, the authorities were not allowing the patients to come to the hospitals. For those people who could have been treated, who could have been at least improve their life or the span of life. So I think so there are so many issues, so that has to be taken. So it is not a single thing. I think there are
Yes.
n number of other issues there.
Uh,
Yes.
I so agree with you, sir, about the celebrity issue. Really, I mean, I feel so bad when they, they go off to UK, US as if we don't have treatment in India, and they're setting such a wrong example. I totally agree with all the points you have raised, sir.
Exactly. And most of our, say, very advanced patients, when we tell them that it is disease control alone or curing is difficult, so they always tell us that so and so person went abroad and got it and got cured. So that makes us feel even more. So this is also something we very often hear in our clinical practices, and especially the new drug which has come up with 18 patients, which everybody has been talking about. So things like that make things a little difficult for us in routine practice.
There are, I'll tell you, there are people, there are patients, so who are going to get a immunotherapy free, targeted therapy free, and this patient has come back to me after 6 months without getting an enrolled. What? So now my somebody is a relative who is a MD or MS. She told, and it is an experimental drug, don't give it. And now those patients have come back now. So there is a drug. So I told them that, so this drug is also has come out of a clinical trial. So
Yes.
there was a different trial for which I wanted to enroll, and you did not come for that treatment. So where you are going to getting that free drug, and these are all patients where the either the original or the generic you are getting it, and suddenly you are talking about that trial. So that in itself is a trial,
Itself is trial, yes. And they are more convinced with that, even though it is a trial.
right?
I think we have Dr. Kripa with us. Dr. Kripa, good evening.
Yeah,
So,
good evening. Sorry for the delayed joining. I mean, I was in a meeting in between hospitals. Sorry.
so Dr. Kripa, we were discussing about the stigma associated with the cancers, that patients reach out maybe at very later stages. They have a lot of reluctance to come and seek medical help. So, what are your views on that, Dr. Kripa?
Not just stigma, I would say maybe, our population is not so educated enough to find out the cancer so early like Western. Usually, even you take the colorectal or be it a breast cancer in abroad or Western side, they're at very early stage. Ours is more neglected. I don't see it's a stigma. It's more of an education, uneducated people, and as well as the neglecting it till, becoming a locally advanced disease. And definitely, I agree with all other panelists like who put forward the view. It's in the education, educated strata. The problem is there, but 80% of the population is not so educated to take forward the treatment. So that is
Yeah,
there.
so most of our patients fall in that group, isn't it?
Yeah.
So another question about establishment of standard treatment guidelines. So what is the current status in India, and do you have any suggestive protocols for standardization? So do we treat everybody similarly,
So
be it
yes.
metro cities or tier 2, tier 3 cities, or do we undertreat them in certain sectors? Do we follow standard protocols of
Actually,
everything?
correct. Yeah, so far, like what we see here is like the EBM guidelines, the evidence-based medicine guidelines are there from TMH. So only that is the last state of what we see. But some topics we have consensus in India, be it ICON consensus, or some consensus are there for like BRCA and certain diseases. Like some active person put forward the ideas and everything. He collected the opinions from various data. Not just that, they have to sit and they have to analyze the whole data. The registries are coming now. One lymphoma registry, very good publication happened from oncocollect.com. And like next, the breast registry is online. Like once we collect the data from all the parts of India, because nasopharyngeal cancer, management will not be same for the EBV positive and EBV negative differs. So we have to take the data from everywhere, and we have to form the consistent guidelines that will help in general, and everyone will understand the epidemiology and management of the disease in total.
Right, right. So, Dr. Rekha, do you feel that we have standardized our treatment options, or do we treat differently, say from hospital to hospital, area to area? Does the treatment vary? Like some people feel things are operable, some say non-operable, some chemo first, some chemo later. So, do you find a lot of differences like this, or do we follow a set protocol?
So right now, I think most of us have been just adapting guidelines. I mean, we are relying on NCCN or ASCO or ESMO. Though the National Cancer Grid is there, but then how many patients would really? So when we talk about guidelines and having our own Indian guidelines, it's not just about efficacy. It's not just about evidence. It's about economics also. we
Yes.
might have we might have NCCN, we can adapt guidelines, evidence from ESMO, but then how many patients will again be able to really take treatment as per our own guidelines? So I think the meaning of guidelines is not just about evidence or just about effect. It's way beyond, and I think that's what the topic today is. So it's beyond medicines. So
Yes, yes,
uh,
yes.
we will have to have a guidelines which can ensure a standard of care treatment to everyone, universally accessible treatment. So I really hope to live that day, but we are very, very far from that.
Yes,
So
yes.
what we can do is, if not immunotherapy, we should have those treatment which are on par or at least as good as immunotherapy and make them available to everyone.
Correct.
So
Like you
I
said,
think that should be
trastuzumab
the
and rituximab and things like that.
absolutely. Yeah. So
Yes,
I
yes.
think right now that is the goal, and I'm sure every doctor is striving for that.
Correct. So though we want
I,
to treat them adequately, probably we end up under treating for various other reasons, and that probably
yeah, I
makes
would
treatment very
say,
bad.
can I add
Yes,
one
Dr.
point
Kripa,
here?
sorry.
Actually, yeah, a lot of Indian studies are coming up. Like as Rekha rightly said, we are not so affordable for 13 cycles of trastro maintenance and all. And a lot of Indian data is coming up now. If you see the ribocyclic, 4 mg versus 6 mg studies coming from TMH, and also OMCT plus paclicarbo and low-dose nivolumab came from TMH. So a lot of Indian studies are there, and the data is getting published. CRSF is collecting from everywhere from India actually. So once such studies which are really Indianized, the OMCT is currently stand option everywhere in the world, not just India, for head and neck cancer. So our population, our studies, our data should be collected, and what is feasible for our country, for our population, economics and all, as Rekha rightly said, if that is published and that consensus was made, that will be really helpful and cater a lot of population in India for sure.
Correct. We'll be able to standardize treatment more than, isn't it? So, Dr. Ghanashyam, sir, any views on this?
So I think Dr. Rekha and Dr. Kripa is already put into that. So if we have the robust data for a low dose immunotherapy, so why not all patients should do? So tomorrow, so when the patents are off for Keytruda and Optida, so we'll have our generics. Even I don't know if you are aware. So we are doing a clinical trial from Dr. Reddy's itself, the Aurelia, so which is an oral PDL1, and so we have completed phase 2. So probably in time to come in next 3 years or so, so we might get a new drug which is affordable.
Yes, yes. And so that way you are also lucky enough to be able to give most of your patients the monoclonal drugs, isn't it? Like your, yes, yes. So, question on funding for cancer research and healthcare workforce. What is the current status in India, you feel, sir? I mean, do we spend enough for cancer research? And do you think there is enough healthcare and health force to do these researches? So, how is the current situation in India?
So in terms of research, I think so. Uh, so few years back, so that span of 5 years was a dark era for those who are into clinical research, when because of that the issues at Indore, then there was a issue at Rajasthan. So one especially with a psychiatric drug, and the other one is the orthopedic drug. So I don't want to name the company. So there were oncology drugs also, since we are a part of that breast cancer trial. So we have been audited. But so what happened? So because of some malintentions at one point a place, so the source note where you can say the manipulated. So there was one center in Jaipur where n number of patients got enrolled within a short span, not in oncology. So that came into focus. And then you saw also the news headlines, and then so that was a dark era of, and you can see there are 480% down or dip into the budgets regarding trials, and especially the CROs who were into the clinical trials in India. And then after reformations, otherwise one PI cannot be doing more than a two trial. All patient has to go through a audio visual. I think so last now 2018-19 onwards, so that things improved. And then that 2.5 years of pandemic came. So again, so there were patients who could not travel. So again, there was a dip into clinical trials. But now things have really picked up. So we recently last year we concluded the ribocyclic, that Ameli trial. So 400 versus 600, which is going to be presented in this San Antonio this year. So I think there are many such trials where we are looking at. So even there is a clinical trial for alpelisib, so where we know that 60% of these patients will land up with some sort of high sugars, so endocrine.
Yes.
So we are doing a part of the trial, so where the anti-diabetic or the GTL2, STL2 inhibitors are put into, so one group, and the other group is going to receive alpelisib. So I think so. So the old wine in new bottle, probably we are looking at with the effective drugs, so that we can we reduce the toxicities, and then these drugs comes into forefront. So I think so lots of things are happening in that area. So repositioning or adjusting with the so something improving on the toxicity profile also.
Right. So, another thing about insurance, since yeah, you and Dr. Rekha also brought it up, certain insurances cover certain government schemes, cover a few drugs, and the cost of cancer treatment in India. So any barriers and possible solutions you would think of? Cost, we already had a discussion saying that it is far more affordable as compared to other developed countries, but still not accessible to most of our patients. One is the economic status per se, the socio-economic status, and second being a lot of disparity in government schemes and insurances. So, do you see a solution there?
So as per my state is concerned, so as I said, so 5 lakhs rupees for a male and a 10 lakhs rupees for a female, right?
Yeah.
So if you keep that in mind and if you set your patient, especially in a curative setting, because the problem in a palliative setting is that you don't know where to land up and how much treatment is going to be consumed. So if a breast cancer is the HER2 positive, so 10 lakhs. So if you choose the original drug and spend 65,000 rupees on a trastuzumab, then probably by the end of even middle of the cycle, you are going to consume that 10 lakhs rupees. So if you choose a generic which is one third the cost, so I think you can able to finish the treatment, the systemic treatment, the surgery part, radiotherapy part, and if at all the patient is hormone positive, you can continue the hormones. So judiciously, as a caregiver, as a physician, as an oncologist, so we need to be also vigilant about that. So that is another aspect as a treating physician. So you know that your hands are only have 10 lakhs rupees or 5 lakhs. So if you choose the right way, then I think so. So many of these patients can be managed, and
Yes.
definitely. So if any money is not enough. So if you ask that every patient has to go for a pertuzumab and trastuzumab, so then it is not, you are not doing. So a HER2 patient should minimum receive chemotherapy and a trastuzumab. So
Trust.
your patients, if you try to put them on a trastuzumab and a pertuzumab, so on the third cycle, the patient cannot have any other treatment in the place.
So there is a lot of cost disparity that we all see. It could be brand to brand, hospital to hospital. Just a offbeat question: do you think the cost also needs to be standardized? So say that there is a particular
Yes,
regimen,
yes,
and this should
definitely.
be the maximum cost.
So in 2000, so when we joined DM, so at that time it was 1,37,000 cost for one trastuzumab, and today you are getting a trastuzumab of 11,500, 12,000 rupees. So it is at least at 12 times it has come down. So 120%. So it is a big boon for many of our patients.
Yes, yes. So Dr. Rekha, anything you would want to add to this?
Uh,
Your
yeah,
opinions on the cost disparity and the difficulties we face with insurances and insurance. You already told us that there is a difficulty about the cost aspect of it.
Yes, I do think cost also has to come down. Like now, okay, like palbociclib generic is coming, so more and more. Of course, I can only hope that the patents for more, the other drugs expire. We get the generics, and again, generics have to be reasonable. So
Yes.
yes, I agree with sir that already we are able to offer many treatments which we were not able to offer even few years back. So yes, but like when we talk about now mutation negative lung cancer patient, if the patient can take chemotherapy, yes, great, but if you are able to give immunotherapy, nothing like it. So
Yes.
really hope that in the near future all of these drugs become very affordable, and we are able to give treatment as good as US and UK, even in India. And of course, when we were to talk about funding and insurance and government schemes, I think it all boils down to the taxpayers. And I don't want to talk economics here, but unless the proportion of taxpayers increase, government funding is not going to increase. So it's a very big
Yes.
problem. And
Yes. So, Dr. Kripa, your views on the same? How is it in your practice? Are you able to give most of the treatments as per the guideline, or do you have to change or undertreat them because of various other issues?
Yes, I do work in a sector where I have both government, I mean, the private and as well general side. So in private side, like a lot of people, 80% would be affordable to the treatment, which is standard for me. But our hospital, 80% is coming on to below poverty category who take treatment for government schemes, under government schemes. So most of the times, like Tasmab I do get, Tasmab I do get. But other drugs, immunotherapy, all these things, I never get.
Yes, that is it. So,
Yeah, yeah.
immunotherapy, do you face challenges even with other insurances, or is it only with the government schemes?
Some certain insurances, because it depends on the limit and everything. A lot of things
Yes,
are there,
yes,
the insurance.
correct.
So yeah, people who have a less limit, I can't offer immunotherapy because of the logistics issue. Most people will come with 5 lakh rupees insurance only to me, so
Yes,
I can't offer immunotherapy to them.
correct. So most of our patients probably fall in that category where we sometimes can't offer drugs like immunotherapy, but otherwise we should be able to manage most other drugs given the current rates we get the drugs at, isn't it?
Yes, correct.
So need a last question, in fact, need of nationalized cancer treatment guidelines in India. How relevant and realistic is it? We have already discussed this. Realistic, yes, because it is already happening, and relevant too, because our subset and the uh, diseases we come across, the types of cancers we see are entirely different as compared to the West or other regions of the world. So we need to have nationalized cancer treatment guidelines in India. So it is very, very relevant to us and realistic as well, since it has been happening, and we have a very good data registries now. So we have to get there very soon. And Dr. Ghanashyam already mentioned that there are a lot of trials happening, lots of things coming up. So, sir, anything you would want to add to this about our data and guidelines?
So I think so. So there have been an effort from ICMR also. So I had been a part of task force in CML and NHL long time back. So led by AIMS New Delhi. So that is also in the public domain also. So I think so where so we have written what has been the minimum. So that is almost like 10 years now. So every 5 years or so. So if we can adopt that and just make that modifiable. So according to the new development. So I think so that will be good. So every kind guidelines like the NCCN guidelines. So every year they are getting updated. So I think so the national guidelines whatever that is available as of now. So that needs to be so said and done. So it is probably not getting updated. So that's also important that needs to be updated so that because since it is in the public domain, so many people are accessing that. So I think so that should be the watch out, or you can look out for those updates.
Right, right. So, in a summary of our discussion, I would say I think the unfortunately the reality even today is that depending on who you are and where you live, it could be mean a lot, mean a difference between life and death for some people. And this can definitely be changed with a structured and a collaborative effort towards awareness and infrastructure development. And we can close this gap of inequity in medicine. And we have had a lot of insight and shared a lot of knowledge about how this can be achieved. And we also know that we are moving towards it. There's a lot being done by the government as well. So, anything in summary, any take-home messages from our panelists, starting from sir. So, any take-home message from you?
So there are 3 points. So one is so we know that this is one disease. So this may not give you any premonitory symptoms like viral fever. So awareness is the key. So be it it's a normal population, be it our medical fraternity. So we should be aware. So like 2 years, people are now aware of COVID. So why not cancer, which is existing for years together? Second is screening. So screening has to come into place at least for a high risk population. So it can be because of addiction, it can be because of a strong family history. So that should be at least there. And third, the clinical trial importance for every people in the society. So that should be there. So they should not run away from clinical trial involvement. So I think so awareness, the screening for at least a high risk population, and the attitude towards clinical trial, especially for the common people and the medical fraternity who are not an oncologist. So I think so these three should be taken care of. Otherwise, the surroundings, everything is in the progress. So it is only to probably watch out. So as Dr. Rekha said, so probably we'll live up to that time to see that, so that every ideal treatment being offered to all of our patients.
Yes, yes. So, Dr. Rekha, any take-home message from your end?
So, yeah, we are all a work in progress. I would only say we should do what we can do. So, in addition to whatever Sir has said, I would only like to add that tobacco and alcohol availability, consumption should be regulated. I don't know if that is possible. That again is not possible. But so we can spread awareness about the damage that these do to the health, and yeah, so modifiable risk factors can be reduced. That's all I'm trying to say. Yeah.
Yes, yes. And Dr. Kripa, anything you would
Yeah,
want to add? A
three.
take-home message for all the listeners?
Correct. Three things I mean, and all my panelists, like other panelists mentioned, three things I'm really keen on spreading. One is genetic clinic and genetic screening awareness, and second is regular cancer screening awareness, and third is research as well as clinical trial inclusion. Other panelists rightly said our population is not so keen on getting tested like routinely, except some strata. Not people are really keen on getting tested for early cancers, like they are not aware of how the early cancer symptoms looks like and how they do feel. So a lot of primary physicians and gynecologists, all this primary contact people should be educated, because most of people I do see in breast cancer, they undergo lumpectomy, simple lumpectomy by general surgeons actually. So a lot of disparities are there. So oncologists should communicate to the general surgeons, gynecologists as well as primary physicians to increase the awareness. What are the modalities are there? So how can we treat the patient? What are the consequences of treating incompletely out of the oncology purview? Like just lumpectomy, a lot of things are there. People will forego BCS and they have to undergo MRM later because of the inadequate surgery. All planes will be lost. So this
Yes.
education of the primary treating physician should be there in our country, which is not there in our country, unfortunately. And second, genetic clinic, genetic counseling is a big stigma in our country. People should come forward to undergo testing, and they have to undergo screening for that. If there is a family history, they have to take necessary measures. Now, genetic clinic is going into a preventive way. Four patients of ours, like I sent for IVF, and the embryos, they are with pregnancy without any defective embryos. They are having the babies like who are not having genetic defects because of the preventive aspect. And third thing, rightly, Ghanashyam sir rightly said there is a lot of scope for clinical trials and research. I myself didn't get grant for two of my projects when I was in residency, being having a very good leaders in oncology with me then. So that should be encouraged, which are genuine. Both the translational medicine as well as clinical research should be encouraged by government. ICMR finding I just got 50,000 rupees for a 20 lakhs project. So that thing should be encouraged by the government, and that will ignite passion in young clinicians. So
Yes.
these three things is my take. I mean, my message from my side.
All right. So thanks so much to all the panelists. It's been a very meaningful discussion we have had today evening, and I must say it has been a pleasure to have you all, and it's been a wonderful discussion. So thank you again. So I think I'll leave it to the organizers now. So